So I'd like to introduce our next speaker now. Professor Andrew Lloyd is a distinguished infectious diseases physician and an accomplished researcher in epidemiology, virology and immunology. He currently serves as the co-lead of the Australian Partnership for Preparedness Research on Infectious Disease Emergencies, or a prize, Insights to Long COVID group. Professor Lloyd holds the prestigious NHMRC Practitioner Fellowship and leads the Viral Immunology Systems Program at the Kirby Institute at the University of New South Wales, and additionally directs the University of New South Wales Fatigue Clinic and Research Program. With clinical expertise in infectious diseases, Professor Lloyd provides invaluable services at the Prince of Wales Hospital and delivers hepatology care to Justice Health in New South Wales prisons. His dedication to advancing medical knowledge and improving community health has earned him recognition, including the Member of the Order of Australia, bestowed for his outstanding contributions to medicine and the community. Professor Lloyd's research focuses on unravelling the intricate interplay between hosts and pathogens in determining infectious disease outcomes. Professor Lloyd's a very busy man, so was unable to join us in person today, but will be delivering his lecture virtually. Please welcome Professor Lloyd.
Thank you very much, Celine, for that kind introduction, and my apologies again for being unable to join you face to face. Can you just confirm that you can hear me okay?
Yes, we can hear you okay, and we've got your slides.
Good as gold. Thank you so much. So like Celine was flagging, I'm going to talk to you from the perspective of a clinician, a physician in infectious diseases, and a researcher that's been focused for a prolonged period on chronic fatigue states, and for this talk, focusing in particular on what we might call post-infective fatigue syndrome, which would nowadays be taken to include the recently referred to long COVID. You will have already noted from presentations in the meeting to date that there is a very close nexus between the phenomenon of chronic fatigue, that's either a physical complaint or a cognitive complaint, and the phenomenon of POTS. My focus is on the fatigue, but I recognise there's a strong co-occurrence. So I'm going to talk about what it is, talk about fatigue particularly from the context of acute infection and post-infective fatigue syndrome, or PIFS, the natural history of post-infective fatigue syndrome, some data about the pathophysiology of post-infective fatigue syndromes, and then we're going to finish by just presenting a little data from studies we did, particularly focused on post-exertional malaise. So first of all, it's important, especially if there are any neurological members of the audience, that we have to separate ourselves from the phenomenon of fatigue as a sign. And what I mean by that, if I'm talking to a neurologist or a neurophysiologist and I mention the word fatigue, that's interpreted as a demonstrable, objective failure of force generation from the muscle. That force generation might arise from deficits in the muscle, or it might arise from what you might call deficits in the brain. And it happens both in the physiological context during exercise, for instance, but may be worsened or modified or heightened in pathological disease states, particularly of the muscle and the brain. One of the first studies that I did a long time ago, actually, during my PhD, was to ask the question whether chronic fatigue syndrome was associated with fatigue as a sign, an objective deficit. And so the graphic on the right illustrates a traditional neurophysiological investigation of that notion, looking in patients and matched sedentary controls at their sustained exercise endurance, seeking to record maximal voluntary contractions using the apparatus you can see in the image. And there was no difference between the patients and control subjects. And we concluded our interest in fatigue in this context is fatigue as a symptom. So what about fatigue as a symptom? It's a subjective experience, as all symptoms are, like dizziness or like pain. And so what the patient describes is what it is. It also can be physiological. I feel tired at the end of a long day, or it can be pathological. I'm abnormally tired. I haven't done much and I'm completely wiped, or in the Australian parlance, we might call it buggered. We do have a bit of a problem in the fatigue business in that the word fatigue really is one that the medical workforce and perhaps the allied health workforce also would commonly apply, but actually it's not one that patients, unless they're instructed in some way, would usually volunteer. Patients will volunteer a whole range of what plausibly are synonyms, but actually could have slightly varied meanings. And that's a challenge for us in this space, because we might be talking about weakness that I've already alluded to. We might be talking about mood disturbance. We might be talking about depression and a loss of interest in doing things physically or cognitively, and a range of similar concepts. And that terminology has just been embellished and amplified and modified in the long COVID space with a different, slightly altered set of terminology. So that's a challenge for us when thinking about how to conceptualize fatigue in infection and post-infective fatigue. So let me try and narrow in on that discussion then in relation to infection. This is a graphic that was published several decades ago by a veterinary scientist who was the first to synthesize the notion of what we call the acute sickness response, which is a constellation of manifestations which he recognized were generalizable across infectious diseases and actually also generalizable across species, not only in dogs that you can see here, but everything from snails to sharks to humans in the context of acute infection. And as you can see, he recorded that it was associated with increased body temperature, a modification in the iron levels, changes in slow wave sleep patterns, changes in observed spontaneous activity and loss of appetite. And he recognized that this seemed to be an evolutionarily conserved phenomenon that was mediated by what at that time were called endogenous pyrogens, so factors from the pathogen and the host response to the pathogen that seemed to be helping the host survive the challenge of the infection, but pay a price with altered symptoms and altered behaviours. And that phenomenon has been further investigated in humans, where we can fortunately ask them about the nature of their symptoms and they can embellish a little bit more. And in that context, it's absolutely clear that fatigue is a premier symptom in the context of acute infection, and that's fatigue in a physical sense and fatigue in a cognitive sense. And it's associated with a range of several of those other symptoms that were in the word cloud, including things like loss of appetite, sensitivity to pain, reduction in mood, and actually social withdrawal as a behavioural observation. And the fact that this is immunologically triggered has been reinforced by many studies in association studies in animals, and also by administration of the relevant biological mediators in both in animals and in humans, like pro-inflammatory cytokines administered to humans. And so it's clear that this is a phenomenon that's immunologically triggered by the pathogen, but not listed on the slide here is the fact that the big black box still in this phenomenon is that it's clearly neurologically mediated. And we understand relatively little about the substrate for that neurological mediation of the phenomenon. Now, all of that's important because, as I'm going to go on to illustrate, the phenomenology of the acute sickness response is tightly linked to the phenomenology of post-infective fatigue syndrome. And that's well illustrated in this data from a study that I led called the Dubbo Infection Outcome Study, which was a large prospective cohort study in which we enrolled ultimately about 500 subjects based in Dubbo in Western New South Wales. And the study involved recruitment through general practice of patients who had been recently diagnosed with acute glandular fever or Epstein-Barr virus infection, Ross River virus infection, which is a mosquito-borne pathogen that causes rash and arthritis, or a nasty bacterial infection acquired from cattle and sheep called Q fever. I've presented data here from just a small subset of the cohort in the EBV group, and you can see on the vertical axis on the right here, the label is the proportion of the group with a symptom, and on the horizontal axis, the natural history of that symptom report. And here I'm just designating what we describe in this study as clinically significant symptoms. So the questionnaire that we used differentiated a threshold at which we call clinically significant. The noteworthy items are, though, that fatigue was a long and strong suit and consistently present. And you can see, consistent with the fact that this is an EBV group, sore throat and tender lymph nodes and other typical symptoms were present. On the right-hand side is a subset of the same study where we identified these individuals as having protracted symptoms for 6 months or more, and then looked back at the natural history of their symptoms from the acute phase into the post-infective fatigue syndrome phase. And the radial plot that's illustrated here has the prevalence of the individual symptoms illustrated around the outside, initially from the acute infection phase of these subjects, and then also in the darker green from the post-infective phase. And once again, the take-home message for this broader array of symptoms is that they're pretty consistent. So it's not like the acute infection and the acute sickness response settles down and then something else comes along and other symptoms appear. Essentially, they were closely concordant. And that immediately gives rise to the notion that the symptom sets, both in acute infection and post-infective fatigue, might share some biological mechanisms. Before I get to talk about those biological mechanisms, though, let me just briefly describe for you, though, the main outcomes of this study, or at least the first 252 subjects in this study. And what you can see here is that regardless of the pathogen in the horizontal rows here, following up over time out to a total of 5 years in the individual confirmed pathogen subgroups, you can see that the case rate for clinically significant post-infective fatigue syndrome was about 1 in 4, 1 in 5 at 3 months, about 10 to 15% at 6 months, about 5% or so at 12 months, and at 5 years it was down to 1 or 2. So there's an important take-home message here that if we carefully apply diagnostic criteria to designate cases, which we did here at 6 months, and follow systematically the natural history, actually the message is largely that of resolution over, sadly, a prolonged period. And my sense is this same data is in the process of playing out in long COVID, and I'll allude to that a bit further. But I flagged before that there's some plausibility in the idea that the biological mechanisms underpinning acute infection and post-infective fatigue, they might share elements. As you'd expect in acute infection, the pathogen is the driver, or at least the initiator. I'm presenting now summarised data from the so-called COFFEE consortium, which I co-lead, which is the collaborative on fatigue following infection. It's got a total of 18 prospective cohorts, like the Dubbo study I just presented. And you can see for each of the pathogens that are listed here, when we ask the question longitudinally, does the pathogen persist abnormally? What we find is that the answer is essentially no. We can detect EBV persists in everybody who's ever been infected, But we found that there's no difference in the viral load, for instance, in blood or in saliva. And the same statement applies for the other pathogens which would not normally persist, like Ross River, chikungunya that causes a Ross River-like illness, SARS-CoV-2, the cause of COVID. For all of these RNA viruses, what's demonstrable is that the genetic material of the virus may persist for more than we would have anticipated, weeks to months, but it doesn't correlate with the protracted course of symptoms in a subset of individuals. And the same statement goes on for the non-viral pathogens, which are part of the coffee consortium, and that includes Q fever, where it's clear that the DNA of the pathogen, of Q fever, can persist for quite some time in a minority of people, but again, not different in cases and controls. And the same's true for adequately treated Lyme disease, where the Borrelia or the spirochetal Borrelial DNA and spirochetal organisms are not more prevalent in those who recover. So we're pretty confident from this data that the pathogen is not the driver of ongoing symptoms. What about the alternative hypothesis? And that is, if it's not the pathogen that's driving the symptoms, maybe it's persistent immune activation. So we've recently completed a systematic review and meta-analysis of biomarkers with a colleague from the Netherlands, Ruud Raasmakers. We identified 20,000 papers potentially relevant and narrowed down ultimately to a quality appraisal and full text assessment of a total of 20 studies which we subjected to systematic review and meta-analysis. And some of the details of this systematic review and analysis and the reasons for exclusion are highlighted here. And the take-home message of this study, sadly for us, which is currently in the process of publication, is there was no reproducible cytokine measure, inflammatory mediator, leukocyte activation marker, gene expression change that associated with post-infective fatigue versus recovered controls. So a reasonably comprehensive examination of the question. I would have to say there are predictably some caveats about this because the scope of markers, these studies dated back up over a prolonged period, so the 21st century application of sensitive techniques may not have been completely well applied. But perhaps most importantly, my sense is that these studies were focused on the blood, and really my gut feeling is, excuse the expression, my gut feeling is the money's in the brain. Okay, changing topic now for the last couple of minutes. I want to focus on the other element that my brief was to address, and that is this issue of post-exertional malaise, which has effectively been alluded to by several other speakers. That is this exacerbation of symptoms in the main topic of this symposium, the post-exertional exacerbation of POTS-related symptoms. But in my case, it's the post-exertional exacerbation of physical fatigue or cognitive difficulties driven by activity, either physical or cognitive, and coming on within hours and lasting several days at a time. As it turns out in clinical practice, this is the key function limiting symptom. It's the thing that's the major constraint. But paradoxically, it is an opportunity to explore the biological correlates of what might be a dynamic change in symptom severity and an opportunity to look for associations of that mild to severe fatigue that might accompany the post-exertional malaise. So we've been exploring this in challenge paradigms, both in physical and cognitive challenge. So physical challenge in the case of cycloergometry. We've carefully chosen the challenge to be approximately 25 minutes of cycle exercise to 70% of the age-adjusted peak maximal heart rate. And the driving simulation, a pretty comparable, cognitively demanding driving simulation And to facilitate this, we've developed an instrument to record subjectively the phenomenology of fatigue in real time. And then we've applied, in association with these challenge paradigms, repeated biomarker measurements. And I'm going to present to you data about biomarkers in the form of leukocyte gene expression and also heart rate variability. So first of all, just it's an illustration of the paradigm. In the top panel, exercise challenge. In the bottom panel, the cognitive challenge. Patients in the black, patients with, in this case, with chronic fatigue syndrome, in the black symbols. Controls in the open symbols. The controls were carefully matched by age, gender, and sedentary status. And you can see that both the physical and cognitive challenge weren't not very challenging for these subjects, which is probably not unsurprising. But by contrast, both at baseline and then immediately after and for a prolonged period afterwards, the patients suffered quite a lot actually from these challenges. But reassuringly, because we chose them carefully to make sure they'd be able to manage this, they volunteered, of course, we chose them carefully and they recovered within 72 hours. So how did they perform in this instance from the exercise challenge? You can see that they were well matched by those characteristics. They were very symptomatic, both at baseline and after the challenge, like I flagged already. And they had a lot of the symptoms you would anticipate, including orthostatic symptoms in this particular group. In terms of the performance, they performed pretty well, actually. They managed the exercise challenge without undue difficulty, but they did report a substantial increase in the ratings of perceived exertion, the RPE, which suggests that they were finding it pretty tough. So what about the biological correlates? Well, the sad news, without going into any of the detail, on the left-hand side is the report of a large number of gene expression markers that we studied, looking for differences between cases and controls and over time between cases and controls, nothing to be found. And then looking at heart rate variability, both in the day and in the nighttime. So they had daytime and nighttime recording of heart rate variability before and after the exercise challenge. What we found is there was a general trend for the heart rate variability to be less in the patients than in the controls, but actually either awake or when they had just gone to sleep, that difference was not significantly different. So some interesting clues, but not substantively different. And I'm going to finish there by acknowledging my collaborators and the funders of the work that I've presented to you, which is NHMRC, CDC, and the Mason Foundation.
Thank you very much for your presentation, Professor Lloyd. One question we've had come through in the Dubbo study, didn't they find there was a difference in genetics, e.g. HLA and post-infectious fatigue?
Actually, in the Dubbo study, we haven't reported this, but we did identify that if we looked at the pre-infection lifetime medical history of patients who ended up having a post-infective fatigue syndrome, we found that they had a higher rate of a prior report of a fatigue syndrome, which does indeed raise the question that there might be either an acquired or a genetic risk factor. We are in the midst at the moment in the Coffee Consortium of doing a genome-wide association study, which we really need thousands of individuals to undertake. And so I'll let you know once we've got that done.
Okay, lovely. Look, in the interest of time, I think we're going to have to leave it there, but please join me again in thanking Professor Lloyd for taking time out to join us virtually.
Thanks so much.
And thank you again for your presentations, Professor Lloyd.